Now, Kate, if you don't mind starting to record from this point, just because I would like, if there are people that need to see this again in the future, I think that it would be helpful for us to have one recording rather than always doing a quick session. So thank you very much. Now if I can figure out how my computer, there we go. So Project ECHO stands for Extension for Community Healthcare Outcomes. The thing about Project ECHO is that it was started in 2003 in New Mexico, and in 2017 we brought it to Northeast Ohio Medical University. And I'll explain kind of how that goes as we go through this. It was launched in 2003 as a healthcare initiative before it expanded into other domains, and it really grew out of one doctor's vision. Dr. Sanjeev Arora was he is a hepatitis C specialist or liver specialist, but he was working in rural New Mexico and realized that because New Mexico is so rural, he has all of these patients with 6-month waiting lists, and we're driving 300 miles one way. And he thought, this is ridiculous. And we teach farmers how to do better things in agriculture, you know, by going out into the community, teaching them to do better. And I talked to my daughters on Zoom, so why can't I teach clinicians who are working in these rural health centers and federally qualified health centers out in the communities to treat hepatitis C where they are? And it's important to know that New Mexico has a really high rate of hepatitis C compared to the rest of the nation. So getting people the right treatment where they are was very important. Within several years of actually being able to track patient data, he was able to prove that the people getting treatment from their family physician or nurse practitioner in their community, if that family physician or nurse practitioner and their team were attending ECHO sessions and learning how to treat hep C in their community, those patients were getting as good, if not better, outcomes from the treatment there as they would have been if they would have been coming to Dr. Arora at the highly specialized clinic at the University of New Mexico. And that's because people, you know, they didn't have the wait times, they didn't have the travel costs, they were being treated by people that had always treated them, and, you know, they would go see if they had the flu. So, you know, for all of the reasons that we know, seeing a primary care provider and that primary care team is beneficial. If you can teach those providers and those teams to treat really complex conditions, then you can get that specialty care right where you are. So the idea is that we're taking, you know, we're making sure that people who need access to specialty services are able to get it at the right place and right time. So the ECHO model is all teach and all learn. It really is a model that is based on flattening the hierarchy. It's interactive. It is not meant to be a webinar, and this is one of the things with early participants we struggle with getting them to understand, we want you to talk. This isn't about us talking at you and you just attending something passively. It is very much an active, engaging community, even though it's done by Zoom. It's also based on co-management of cases. So it is telementoring, it is not telehealth, because what we're doing is we are collaboratively coming up with solutions and collaboratively giving input to whatever the complex case is. Dr. Arora noted that when he did his fellowship, what he did was case-based learning. They would have a grand rounds for, you know, so some type of didactic on evidence-based and scientific, you know, what the research is saying about how we should treat this condition. And then they had case-based learning, and they would discuss cases and come up with solutions. And one of the things that Dr. Messamore, who you're going to attend his session today, what he says pretty regularly is if a textbook doesn't have a solution to the patient, to the problem that your patient has, maybe your peers will. So it is that peer-to-peer learning. It's co-management through, you know, telementoring and, you know, through that collaborative community, and bringing all of the collective expertise together at one table. So while the experts are, you know, at the hub, and you'll see Dr. Messamore and Dr. Dugan later, and they are the experts, really everybody is bringing some different type of expert to the table. Our collective expertise is much more powerful than anything individual. The principles of the ECHO model are to use technology to leverage scarce resources. So as in today, Dr. Messamore and Dr. Dugan are experts in treating schizophrenia. They've spent a lot of time in their careers specifically doing that. Dr. Messamore has done a lot of research around it, but he's a scarce resource. He also has a lot of really good expertise, but so do all of the other individuals at the table. And you'll see that that group in particular is the broadest group that you'll see across all of the programs, where we have actually NEOMED grads from Arizona who routinely join and are bringing their expertise to the table too. It's sharing best practices to reduce healthcare disparities. We want to really truly provide more of equitable health across all areas of the country and the world, and by sharing best practices, we can start to do that. Case-based learning to master complexity, and web-based data to monitor outcomes. The outcomes is a little bit hard, but we need to start getting there. We need to prove that if we're able to do this, that we can achieve better results. And Dr. Aurora was able to do that. And obviously collecting patient level data and practice change data is harder, but when places are able to, and those that are using this model are able to do that, you see really that we are actually able to make a change in the outcomes that people are getting by doing that. But when all of these principles are put together, the point is that all teach, all learn. So we're all here in this together. So how Project ECHO does this is through a couple ways. One is the evidence-based didactics, but the didactics are small. Just like this, it's 10 to 15 minutes, a little bit of a snapshot of a particular topic. It's 2 to 3 take-home points. So when you're seeing, let's say, a didactic on motivational interviewing, you might get one piece of the motivational interviewing today. You could probably do an entire series of didactics on motivational interviewing because you can only really take one small piece and do it in we like to call them a didactic blitz, because it's not your typical lecture. It's here's a couple things, they're real takeaway points, and then let's talk about them and let's move forward. It's also through these learning loops, so case-based discussions, practice recommendations, application of knowledge to real people, and then the knowledge network, so participation in the case-based discussion, and providing the additional expertise, somebody being at the table that has a different lens or has seen something in a different way. It's through all of these things that Project ECHO does advance clinical practice. The idea is to move knowledge, not patients. So it's a hub and spoke model where you see the hub, and typically we would run sessions at the NEOMED with a small handful of individuals, including Kay or another coordinator in the room running all of the tech and doing things that look like magic to me, because I can never quite get the tech to be right like that. And then everybody who's calling in from the communities. Now, over the next 2 weeks, your engagement in Project ECHO is going to be really unique because everybody's at home. There's not a hub at NEOMED with our nice Project ECHO sign in the back. It's really everybody's trying to do this remotely, but what a brilliant thing to be able to have this right now. Project ECHO is all about doing more for patients. And when we say patients, that's used loosely because one of the things you'll see in a couple slides ahead is that you can use Project ECHO for anything that's a complex issue. So there are systems that use this entirely for education, and they do professional development and ongoing professional education and use the model for their K-12 teachers across the state. India is using it for their entire public health. So this isn't about just patients. I mean, sometimes it's even about systems. So a case might be a system issue, or a case might be with education. How do we improve test scores? But it's whatever the patient is and whatever that's identified, our target of what we're trying to improve is the right thing, the right care at the right place, the right time. Providers are increasing their capacity by becoming more skilled to treat more complex conditions, and by giving the resources so that they have the confidence and the support to do so. At a community level, we want to reduce health disparities. We want to retain providers, reducing burnout, and keeping patients local. And with the system, we definitely want to improve quality, reduce costs, increase access. So that triple aim, this is all very much tied into the quadruple aim too, because we can address provider satisfaction with Project ECHO. So here's just a visualization of what we've talked about. So you've got some subject matter experts that are working with the community to practice, and they're having the knowledge learning loop through the dialogue. But then on the right-hand side, it's the people reached. So not only are we reaching, for each physician who attends, or counselor or social worker who attends a session, we're not just reaching their patients. We're reaching all of the patients in their practice potentially. We're also reaching, the patients of the people that they work with, because now we've had counselors who take what they learn in ECHO sessions and use it in supervision. So now that counselor that they supervise, all of their patients are now impacted. So we can really create what is the word that Dr. Aurora uses? I'll come back to it. So what is Echo into? And I pulled this screenshot just so you can get a little bit of a snapshot of it. And there are links at the end of this that I do highly encourage you to really dive in, because NEOMED currently is using them for mental health issues, but we're going to be starting a geriatrics Echo very soon. And you can see that you can use Echo for all kinds of stuff, and it's being used globally for a ton of things. So domestic violence, emergency care, women's health, LGBT health, HIV, ethics, hepatitis B, nutrition, metabolic disease, sports medicine, law enforcement. They do use this for CIT officers, so that's the crisis intervention teams out in New Mexico, social welfare. There's so many possible uses for Project Echo and this is just a very small snapshot. Okay, so with Project Echo, we believe, and we're starting to be able to show that we can address major, huge global goals. So improving, equality education, reducing health inequities, creating sustainable communities, improving general health and well-being. And they do link into the UN Sustainable Development Goals, because what Project Echo is trying to do is very much in line with what the World Health Organization and the UN are trying to do for people globally. So I mentioned to you that Echo started in 2003. So you could see they really only started tracking how far their reach was getting. So this is the cool thing. When you sign up to become an Echo hub, you sign an agreement that says that you'll follow those principles, so the amplification of leveraging scarce resources, case-based learning, monitoring outcomes. You sign up to agree to follow those principles, and then they give you everything for free. So what Project Echo has been able to do is spread this model very rapidly. So you could see when they started tracking this and started giving the model away to other places in 2006 up to 2020, they've gone from a couple of hubs in New Mexico to now 387 hubs across the world. Those hubs make up 838 programs across 39 countries. Almost 100,000 learners. And their goal is to touch 1 billion lives. So 20,000 organizations in 5,700 communities. The learners are coming from 153 countries. So this is a huge number of people. And when you look at it on a map, which we'll get to next, the whole idea of this, we are trying to build a global community. And that's what my experience has been with Project Echo, is being able to really tie. It makes the world feel a little bit smaller. So there are programs in North and South America, Europe, Australia, France, Asia. There were people at my training that were from New Zealand. We've routinely connected with our folks, with the teams in Ireland. It does makes the whole world feel a little smaller. So you can see from this map of the states, this is where we have active hubs and super hubs. And NEOMED is about to become the next super hub. We should have been in training for that this week, and we've been announced to actually be a super hub. We just have to go through the training in order to function as one. And a super hub really just allows us to help train more places to become hubs. So all of these are scattered across the country, and each one of them is going to have a different focus area. So just like I said, NEOMED started with psychiatry, and it's going to continue to grow. Each one of these individual hubs and super hubs is going to offer a little bit of something different. Globally, oh, that map didn't come out very good. Sorry about that, trying to do screenshots. You can get a little bit of a sense of it. So there's quite a bit in the UK, quite a bit in Australia. India has picked up on this very much, as have parts of Africa. And the idea is to change the world fast. If we're going to hit 1 billion lives by 2025, we really need to keep doing this. And the idea, again, is to continue to enable more people who are working in rural and underserved communities to get the expertise that they need to address the complex issues that are presented in front of them. The other thing that you sign up for when you sign up to do Project Echo, though, is to follow these 7 values. Because the values and the 4 principles and these 7 values are the core of Project Echo. They will give you everything for free, and they connect everybody through Box so that we can share materials and share resources and tap into each other's knowledge knowledge, but what we promise to do, and we actually sign legal documentation making this promise, is to abide by these values also. And these are the things that make Project Echo so valuable to me, is that we really are doing something out of the idea of service to underserved, providing excellence and accountability, demonopolizing knowledge. Nobody owns knowledge. So we have to get away this idea of like intellectual property with Project Echo, because intellectual property it's a lovely idea, but it doesn't mean anything and it doesn't really help people. So this is all about giving away the knowledge that we have to make sure that everybody has access to it. It's also built on trust, respect, and teamwork. And the kind of the accidental, real beautiful thing that comes out of it is this joy of work. It sounds campy, I know that. But doing Echo, even when it's really hard and there's lots of things, and pulling things together this last week has been a challenge. It does provide joy and that sense of community that I've not been able to get other places. So NEOMED is the Department of Psychiatry is funded by PEG's Foundation. PEG, Margaret Clark Morgan, her and her husband had a son with schizophrenia, and they have a large foundation, and they've been pushing and supporting the work within the Department of Psychiatry for years. But PEG's big thing was think bigger. That's what she would tell everybody at the foundation. That's what she would tell us, and that's what we've started to do with Project Echo. So we have 6 programs. We have the Integrated Care, or ICANN Echo program. It is Integrated Primary Care and Mental Health. We have a first episode psychosis program, the 2 opiate programs, continuing education and mentor. We have SC Consult, and I put an asterisk next to Ohio Systems of Care, because that is the one that you will not be attending. And it's for a couple reasons. And I want to be honest about what those reasons are. One is that it's a very large community as it is, and it's fairly complex. It is those providers working throughout Ohio on the most challenging kids. So they're the multi-system youth, so kids who are involved in Department of Job and Family Services. So maybe they're in county custody due to abuse issues or behavior issues. Many of them are in residential treatment. Many of them have developmental disabilities and mental health issues and chronic health conditions. So that it is probably our most sensitive population and the most complex team to get involved in, but it's really, they have so many participants that adding extra to it, I didn't want to overwhelm our coordination staff. So hopefully at some point we can do that. It's just that program's a bear right now. Really needed, but actually I want to go back to that if I can. Okay, yes. So, but aside from that, what we've been able to do, we started the Opiate Echoes in November 2017. Since then, you could see that we've been able to do a lot. So with 59 staff, we've pulled off 488 sessions, which is almost 1,300 hours, which when I saw that number, I thought, oh my God, we really have been doing a lot. 570 distinct participants with an average attendance of 9.3. So that's an average attendance of 9.3 per session. And the integrated care are smaller sessions. Sometimes our average attendance at the systems of care is about 30, which is a lot. They're highly interprofessional. While we track a lot of physicians who are attending, there are a lot of people that are listed in our numbers as other, because within the systems of care, first episode psychosis, these are unlicensed direct care staff. So they are working in group homes, they are working as a case manager, they might be working as a supported employment specialist, so they don't necessarily have a licensure for us to track, but it's a highly interprofessional group. So pharmacists, counselors, case managers, advanced practice nurses, we run the gamut. It is one of the most interprofessional things that I have been able to have the pleasure of working within. We've had 129 formal case presentations. I say formal because this is actually us knowing, hey, Dr. Ballister wants to present a case today, and then we listen to the case and we send recommendations. But there are countless curbside consults and random questions. And what we really have been able to build in all of this is real community. So typical Echo session, you're going to have intros like we did, and then it's going to be a brief didactic blitz, 10 to 15 minutes, depending on the program and the total length, but our goal is usually 10 to 15 minutes. Hopefully a case presentation. That can be variable, but the goal is to always have a case presentation or some kind of dialogue around a case so that we have case-based learning. Within that case presentation is discussion and recommendations from all participants. So when you are participating, If there's something that you have a question about, you should ask that question. If you have knowledge in something, provide that knowledge. And we very intentionally have peers and family members on as many of these programs as we can, because we don't want to lose the patient's voice either. After all of that, then it's wrap up and announcements, and then on to the next session the next week. So some Zoom etiquette. I definitely recommend that you test your equipment. This is today, what we're doing right now is a good opportunity to do so. If you decide to call in on the phone instead of joining through your computer audio, you can use *6. What I did today is I joined by the computer, but then I called in through my phone anyway, because it does reduce the internet burden. So I feel like things get less glitchy then. So I'm both on my phone and on the computer. Try to eliminate or reduce environmental distractions. I'm so lucky right now. My husband took one of our dogs downstairs, because typically what you would see behind me is some kind of chaos and dogs are barking. And I was really hoping that wouldn't occur while we were doing this. At the end of the day, I guess I don't mind so much, but try to make eye contact with the camera when you're speaking. Be conversational, and keep in mind that there's going to be some awkward silences. It takes several seconds for someone to make a decision that they're going to jump in, and then sometimes a little bit more to unmute their microphone. And sometimes we have people that are not great at unmuting their microphone, and our coordinators do a stellar job at trying to watch those individuals and make eye contact, which is why the video is so helpful to know, okay, I'm going to help them unmute real quick. So how you can participate in ECHO sessions. Contribute to the meaningful discussion. If you have questions, like I said, ask the questions. One of our UK partners brought up he calls it the bozo question. So if somebody doesn't, there's always going to be somebody that doesn't know part of what somebody's talking about. So ask the question that seems a silly one. Give input to individuals. Be supportive. Sometimes when people are presenting cases or talking about what's been going on, really all they need is someone to say, hey, I've experienced the same thing, and that's really hard, but you're doing a really good job. And that's one of the cool things that comes out of Project ECHO, is being able to do that. So be respectful and open your mind to diverse views. Sometimes you'll get diverse views, or you'll hear people using out-of-date language. My typical go-to is, well, yeah, that's true, and now we know that we should really be referring to things in these kinds of terms instead. Being supportive and mindful of who isn't in the room. So thinking from a patient's lens, thinking from a family member's lens. What are the questions that we aren't asking because we're not thinking about it from their perspective? And maintain confidentiality. We try really hard with this, and for the most part have a lot of success, because we don't want to have our hands tied by HIPAA regulations. So we ask people, if you're talking about a case, just know protected health information. Don't use names. Don't let us know who they are, to the best that you can, because this is about that telementoring and consultation, not about actual telehealth. Benefits, again, this one's a little pixelated too, which I'm disappointed with, but benefits of becoming part of an ECHO community, it's access to community, reducing disparities, rapid dissemination of knowledge, promoting consistency in practices. So Dr. Messamore in particular is very good about this. He's trying to push for people to become better with their use of clozapine, and to do so thoughtfully and intentionally. And him and Dr. Dugan have developed an entire service based on trying to not only teach people how to use clozapine, but be an ongoing support. Increasing your professional knowledge and decreasing isolation. And this is one thing that we do hear from our community members. There are people we have that join, particularly the Friday sessions, the integrated care, that are working out in rural areas. And not only does this help them stay on top of what are the best practices, but also they would be very professionally isolated otherwise. Even working within a city, you can become very professionally isolated. With our opiate echoes, this is something that we've heard quite a bit, is that even people who are working in, not geographically isolated areas, but there's still a lot of stigma to being a medication-assisted treatment provider. So sometimes they're not getting the support from their colleagues that are in their office. So having a community where they feel supported and understood and have that sense of community there is really important. So to learn more, go to our webpage, so neomed.edu/Project ECHO. If you want to learn about ECHO more globally, which I highly encourage too, echo.unm.edu. And you can also follow us on Facebook, Twitter, and LinkedIn. And I'm going to stop the share. Questions, comments, thoughts? And just jump in, unmute yourself and
if you look in your chat box, I've added the registration link for each of the echoes. And it's a web page, and you should be able to get it through the remote student web page as well. But the link isn't there right now. But that is the link you need to register. Then you're given the link to get into the ECHO program.
thank you, Kay. And so that would be for ongoing participation. So for the next 2 weeks, as part of your clerkship, you want to follow the links that were shared by David and, as part of this coursework, the way that you will for SC Consult. But if you want to continue, attendance in any of the ECHO programs on an ongoing fashion, either during this year, next year, or throughout any portion of your career, absolutely register there. Because once you register there, you're going to get information about whatever program you click that you're interested in, pretty much indefinitely. We will, possibly slam your email until you tell us not to. But we also have a lot of resources for our communities. We have a library guide for the integrated care program that includes literature that came out of, a literature search that came out of some random discussion that happened in the session, videos of all of the previous sessions. And when I say videos, it's just of the didactic portion. We don't want to accidentally catch PHI on a video. So we do record all of the didactics, and those are available on YouTube. We're trying to do the best that we can to create some community outside of just the session time. Well, what questions do you have? Or what comments do you have?
Just to clarify, do we need to register for each of the ones according to our course right now before we go on the Zoom?
No, so there is the link sent out by David, a link for each session that over your next 2 weeks, and you will need to follow that because we're trying to capture attendance. So the link that Kay just shared in the chat box is if you want to just stay on top of this on a more ongoing basis. You'll want to follow the directions that were sent out by David and Dr. Knopfinger for the next 2 week schedule.
Okay, and then one more thing on our schedule. One of the things on Friday, it's it says it's at NEOMED, the integrated care at NEOMED. Is that still a Zoom link?
Oh yeah, it's just we had a team member that was cleverly into marking. It's definitely not at NEOMED. It's definitely on Zoom. It's like integrated care at NEOMED.
Gotcha.
Good question.
Yes, all
Thank
on
you.
Zoom. Now, once we get through all of this COVID-19 nonsense, if you are on campus, and when everybody's back on campus, if you're on campus and you want to join a session in person, we do most of the sessions in the psychiatry conference room. And next year there will be 2 elective clerkships where you can do, it's a non-clinical clerkship, but so one of the rotations, one specifically about the opiate echo programs, and there's Kate could probably say more about that because there's more than the opiate echoes that's involved with that. And then the other is around all of the things that psychiatry is doing with Project Echo, but it's just really an opportunity to do a deeper dive into Project Echo and learning more about it. So that's an interest, and those are on campus or on Zoom, I guess. We'll see.
And everyone, we added a slight reflective piece for this. You only have to do one after you do all the echoes. It's not for each echo. From your standpoint, I think it's actually nice to do. Our goal is for you guys to think about telemedicine. This is a way every hospital is going in all fields of medicine. So we want you to reflect on your experience, and then if you have time, just to kind of think about where you see yourself kind of interacting with telemedicine going forward, because I will tell you there's even a big push from the Children's Hospital that I work in. So this absolutely will be part of your future. From the boring side of things, I have to prove to the LCME and the AAMC that I'm assessing you guys. So other than attendance, I know it seems silly to throw some of these things in, and you are probably already doing this on your own, but just know from that standpoint, I want that just to be sent to me because we're collecting everything from our end. Because your actual clinical rotation in psychiatry will be shortened no matter what happens with all of this. So please know that that's there. Again, I do think it's a worthwhile activity. We're not just throwing, stuff at you. It's only a page or two, but I think it's worthwhile to think about because we think about it in pediatrics, for strep throat. I don't know that that's a great time to do telemedicine, but there are a lot of other things that we deal with in pediatrics that are anticipatory guidance, upper respiratory tract infections, respiratory distress, that kind of thing, where telemedicine can play a really big role and help with societal problems like people trying to get to work and people, in remote areas or people who don't have a car to get to or have to take 3 buses to get to their doctor's office. So just so you know, that component was added in.
Dr. Knopfsinger?
Yeah.
So for that writing assignment,
Yeah.
In the instructions, there's is this supposed to be an article also associated with that?
No, that's what we just gave you a title because we wanted to kind of guide your thinking. But I want to add into that. So we want to guide your thinking as far as, how was this experience, but also where do you see yourself in this kind of going forward. But there's no article.
Gotcha.
Just to add something about the telemedicine, I think that this could be, like the echo could be used a lot between residents, like in a situation even like the COVID that's going on right now. A lot of like the social media accounts I have is internal medicine residents talking with each other about how their hospitals are planning for this huge influx of patients. So I feel like something like echo would be a good way for those residents to say, oh, my hospital's doing this and it makes a lot of sense. But then some people saying, well, my hospital's doing this and I'm like scared for, what's to come. So.
Yeah,
Thank you. I think that's a great point. So just to let you guys know too, in addition to our regularly scheduled echoes, we're going to be having a couple pop-up echoes on COVID-19 within the next couple weeks. I'm trying to look at my calendar right now to see when those are going to be, because I think one is going to be...
Nicole, we're going to share those with everyone. So we will,
okay.
Our plan is to ultimately share those things with all the students, not even just our students on psychiatry. So you don't have to give them the date. We'll send out information.
Excellent. Yeah, excellent. Thank you. So one is going to be really about the virus itself, and the other is going to be more focused on helping manage the stress and anxiety of living in a pandemic. So yeah, when you get those, and please feel free to share the information once you receive the information about those 2 echoes, because they won't be as engaging as our typical, like we're not going to do the introductions at the beginning, particularly if we get a large audience, but we really want to open it up to a very broad audience so that people have access to the information and have access to some resources. And it might be one of those things that turns into a more regular ongoing thing, because to April's point, we could be doing this, residency programs could be using this for just about anything, but COVID being one of those. It's a great educational tool for students, for residents, for existing providers. And it is actually a lot of fun. It's nice to have the community, and that's something that you don't get a whole lot of. And you guys will get to hear actually, so we did put a call out to all of our participants to please bring cases, and because we've got students who are going to be attending, so we've please, bring stuff that they're going to be able to learn from. And we have had some of the most fascinating cases in all of the sessions that I've attended in the last couple of years. We get some pretty interesting things. So while you're not in hospital or outpatient rotations right now, I still think I'm hopeful that you will have a nice opportunity to hear some very interesting, unique patient stories and cases that you might not otherwise. Well, if there's no other questions, we can go ahead and sign off. I know that Dr. Langell was doing a thing at 10:30, and then you guys are going to be logging into SB Consult at noon. I'm available and around at NEOMED, electronically, obviously now. But please, if there's ever a question, reach out. If you have interest in ECHO or in whatever way I can be a resource, please do just let me know.
Thank you.
Thank you.
Absolutely. Well,
Thank you.